Hello, welcome to the EKG Guy, and welcome to the EKG of the Week. I hope you're having a wonderful week, and I'm glad you could join us. This week's case is a 33-year-old thin male with newly diagnosed miliary TB and AIDS that developed shortness of breath. His EKG is shown here. Now, before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below. On the right side of the screen, we have a list that we'll go through before making our final interpretation. First, there is the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we have the rhythm origin, that is, where's the rhythm actually coming from within the heart? Then we have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. Then there's the atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal in any area of the heart. Then we have the waveforms, which would include all the waves, the segments and intervals, and lastly, anything else, meaning is there anything else that we've missed or need to mention? We'll look at the R wave progression and transitional zone in the precordial leads. Now after that, we'll use all this information that we've gathered to make a final interpretation and then make a final comparison to a previous ECG if available. Now I want you to pause the video, take a few minutes to go through it yourself. When you're ready, start the video and we'll go through it together. Alright, so our 33-year-old thin male with newly diagnosed miliary TB and AIDS develops shortness of breath, and this EKG comes about. So let's go through it. So first, let's look at the regularity of the rhythm. Well, on first impression of the EKG, you probably noticed that this rhythm appears to be quite regular, and that is correct. This is a regular rhythm. Okay, so in terms of the regularity, we have a regular rhythm. So let's look at why that's the case. Okay, now typically when we look at regularity, again, one of the easiest things is to pick out those large R waves in the ventricular or QRS complexes, and you can take one of these rhythm strips. We can use this one down here in V5, and we want to look at the intervals, okay? We want them to be consistent, and that would mean we have a regular rhythm. So if we take the R to R interval, which means from one R wave, okay? Remember the R wave is the first positive deflection after a P wave, okay, of the ventricular complex. So from one R wave to the next, we call this distance from one to the other in R to R interval. Now, if we have consistent R to R intervals throughout, meaning from this R wave now to the next one, and if this continues throughout, such that all these R to R intervals are constant, okay, we would call that a regular rhythm, okay? And if you were to use your calipers or a piece of paper to measure these out, you would see that all these R to R intervals are the same throughout this rhythm strip. So we call that a regular rhythm, okay? Now, what do you get for the heart rate? Well, because we have a regular rhythm, there's a couple ways we can find the rate here, okay? One would be to simply count out the number of ventricular complexes going across the EKG, multiply that by 6, because we know that the standard EKG represents 10 seconds in duration. All right, so let's do that. First, erase this here to clear it up. Okay, so remember, the standard EKG represents 10 seconds, meaning from beginning all the way to the end here is 10 seconds, and 10 seconds times 6 is 60 seconds, which is 1 minute, okay? 1 minute. So meaning if you were to count all the complexes going across, multiply by 6, you can get an estimate of the rate in beats per minute. And we'll look at the ventricular rate here. So we'll count the ventricular complexes, multiply by 6 to get the rate. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. Okay, so we have 19 complexes. So what we would do is take 19, multiply it by that 6 here, and 19 times 6 is 114 beats per minute. Okay, so that's an estimate of the rate. Now, another thing we can notice here is notice that our rate is fast, above 100 beats per minute, so we have a tachycardia going on here. So instead of using that 300 over the number of thick lines, a more accurate way is to find one of an R wave that falls on one of the thick lines. So let's do that here. Okay, so we'll find an R wave that falls on one of them, and we can, let's see right here. Okay, we can use this one. Notice it's falling on this thick line. We're going to find the next R wave, which is here. Okay, and if you were to count the number of small boxes between this, you'd actually get 13. Okay, and because we're dealing with a fast rate, a more accurate way of doing it, instead of 300 over 3, which could be about 100, you can do 1500 okay, divided by the number of small boxes between the R to R interval, which is 13. Okay, and that would give you a rate of about 115.4 beats per minute. Now, the EKG machine actually gave us a rate of 117 beats per minute. Okay, so regardless, faster rate, but you can see this is a little more accurate. All right, so now let's move on to the rhythm origin. All right, so we'll erase this so it's clear. All right, so rhythm origin, that's where is the rhythm originating from the heart? Well, we have narrow QRS complexes, so it must be supraventricular in origin, okay, meaning that it's originating from above the ventricles. We can also make out clear, defined, similar shaped P waves in each lead. So we have to ask ourselves, are we dealing with sinus rhythm, okay? So let's see here. Now remember, sinus rhythm, if we have our heart here, remember this is our right atrium, our left atrium, right ventricle, and left ventricle. When we talk about sinus rhythm, that means the rhythm is originating from the sinus node that sits here in our near our superior vena cava, high in the right upper right atrium. We have our internodal pathways that come to our AV node, the His bundle, the Bachman bundle to the left, right bundle branch, left bundle branch that subdivides in a left anterior and left posterior fascicle, and then from there they innervate the cardiomyocytes and the impulse spreads. Okay, so when we talk about sinus rhythm, we're saying that it's coming from this region here. Okay, so if we were to take a one of our grids here, or quadrant system, we would see that this would be 0 degrees here. This is positive 90 degrees, plus or minus 180 degrees. Okay, and then we have negative 90 degrees here. Remember, lead 1 sits here, the positive end, lead AVF down here, okay? And then we would have lead 2 sitting at positive 60 degrees, okay? And then in our horizontal plane, we would have like V4, V5, and V6, all right? AVR would be in this case, and then lead 3 is here, all right? Now, what I want you to do is imagine that we would take this right atrium here, okay, just the right atrium, and we superimpose it on this grid, all right? Now, imagine we have our sinus node here, okay, and then our internodal pathway. So the impulse is heading in this direction, okay, and here. And because of that, when we look at P waves, the normal P wave axis originating from the sinus node should be between 0 degrees, which is here, and actually positive 75 degrees. So this is normal P wave axis. That means if the P wave or the atrial impulse is originating from the sinus node or close to it, and the impulse heads in this direction, we should see upright P waves in these leads. And we should see negative P waves in AVR, okay, because the impulse is moving away from AVR. So we should see negative P waves in that lead, okay? That's if the rhythm is originating from the sinus node or close to it. So let's look at this here. So if we look at lead 1, here's lead 1, you can see these upright P waves, okay? If you look at lead 2, the same thing here. These are all upright P waves. Notice that the same morphology, V4, right? This left lateral leads, and here's V4, V5 and V6, same thing. All the same morphology. Notice that they're preceding every QRS complex. There's a 1-to-1 ratio. And then when we look here at AVR, we see these inverted P waves, okay, preceding a QRS complex, just as we would expect in sinus rhythm, okay? Now, a few other features of sinus rhythm. Remember, we want the P waves to have the same morphology. So if you were to simply take a look at any of these, if you look at lead 2 here, just look at all the P waves throughout, they would have similar morphology, okay, if you were to go through this. And notice that there's that 1-to-1 ratio, 1 P wave for every QRS complex, and the P wave is always preceding that QRS complex, okay? So those are all components of sinus rhythm. So because we have that and we meet all that criteria, we are in fact having a rhythm that's originating from the sinus node. So we have sinus rhythm, or SA sinoatrial, okay? So next we have to look at the ventricular or QRS axis. Okay, so let's again erase this also. There's no confusion. All right, so ventricular axis, and we're going to use the QRS complex when we look at that. Ventricular meaning it's coming from the ventricles, and our QRS complex, remember, represents ventricular depolarization. Okay, so when we do this, we want to get here, and you should have gotten a normal axis. So the actual axis here was normal, and it was positive 63 degrees. So let's just look at what is considered normal axis here. Okay, so if you draw out our quadrant system, again, remember this is 0 degrees, this is positive 90 degrees, plus or minus 180 degrees, and we have negative 90 degrees up here. This is where lead 1 sits, the positive end. AVF down here, okay? And what we want for normal access, it typically lies between negative 30 degrees and about positive 105 or positive 110 degrees is considered normal axis. So all this here is normal. When we talk about right axis shift, it tends to be in this region. This is left axis deviation, okay, or pathologic left axis deviation, okay. This is more that physiologic or normal shift towards the left axis, and this is northwest axis or extreme axis deviation, sometimes called no man's land, whatever the case is, okay? And you often don't see that. Sometimes you can see that in VTAC, where the axis, you see a complete shift, and that can be one of the signs that we see with those wide complex tachycardias that can point you to more VTAC, but we don't have that here, so we won't get into that. So we said the axis here was what, positive 63 degrees. So when we look here, that means that the axis is coming somewhere about right here, okay? This is about positive 63 degrees, okay? And let's look at why that's the case, okay? So what we have here is lead 1. So look at lead 1. If you were to measure the differences of the QRS complex, right, you would see that it's mostly positive compared to the negative portion of it from baseline. That means we would be heading towards the positive end of lead 1. If we look at AVF, you can see these are mostly positive complexes, so we'd be heading towards the positive end of AVF, and that would mean we're heading in this direction. And then remember, lead 2 is pretty much at positive 60 degrees. This is lead 2. If you look at lead 2, it's almost all completely positive, so it makes sense why we're heading there, and the actual axis we said was positive 63. So that's why we have a normal ventricular axis, all right? Now, how about atrial conduction? Well, typically we look at leads 2 and V1 for P wave or atrial abnormalities, as they appear to be the most evident in those leads. In leads 2 and V1, we don't reach the P wave amplitude for right or left atrial enlargement. The total duration of the P waves in leads 2 and V1 appear to be within normal limits, which is less than 120 milliseconds or 3 small boxes, okay? So again, when we look at atrial abnormalities, we're checking out those P waves, and you often want to look at lead 2 or V1 that tend to be the best leads to look for those abnormalities. All right, so we don't see any here, so we have normal atrial conduction. Now, how about atrial ventricular or AV conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and ventricles. Because the majority of the PR interval represents AV nodal conduction, we tend to look there. The normal PR interval in adults, which we have here, a 33-year-old gentleman, is between 120 and 200 milliseconds or 3 to 5 small boxes. In this case, it appears that the PR interval is within normal limits. In fact, it was actually measured by the EKG machine to be 154 milliseconds, okay, so within normal limits. So again, AV conduction here is normal. The PR interval, just so you're aware, was 154 milliseconds, okay, so normal AV conduction. Next, let's look at intraventricular conduction or IV conduction, and here we look at the duration of the QRS complexes, okay. The normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. Some may consider the upper limit to be 120 milliseconds, but again, anything beyond that 110 milliseconds is generally abnormal. Anyways, the main thing here we're looking for when we look at intraventricular conduction is whether or not the QRS interval is prolonged. On this ECG, we can see narrow QRS complexes that appear within normal limits. In fact, the QRS duration here is 72 milliseconds, which helps confirm that IV conduction is normal. Okay, so normal IV conduction, QRS interval here we said was 72 milliseconds, okay, so within our normal limits. Now, how about the waveforms? We already discussed the P waves. We said they're normal. The PR segment here does not appear to be significantly elevated or depressed. We said that the PR and QRS intervals are within normal limits. There are no abnormal Q waves or QS complexes present that may suggest maybe a prior infarct. The ST segment does not seem to be significantly depressed or elevated throughout the ECG. The QRS amplitude does not seem abnormally increased or decreased throughout the ECG. Okay, the anterior precordial leads do show some large voltages, but this is likely because the patient was a thin male here, okay, and these are these large voltages here you see in these anterior leads, likely because we're dealing with this thin male patient. They're sitting right on top of the chest or precordium, okay. Now, in terms of the T waves, they're normal here. They're asymmetric in morphology, that slow upstroke and that steeper downslope that we want to see. Okay. And lastly, with the waveforms, the QTC interval was actually slightly prolonged here, calculated to be 456 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds. In females, it has a little upper limit, about 460 milliseconds. So overall, when we look at the waveform abnormalities, what we see here is a slightly prolonged QTC interval, okay? And we said here that it was 456 milliseconds. Now, is that a concern? Not often, right? If we give any prolonging medications, normally if it's up, you would get a little more concerned about giving them around 500 milliseconds, about precipitating any ventricular arrhythmia such as torsades. But in this case, that is one thing that we should be aware of. Slightly prolonged QTC interval at 456 milliseconds. All right, so is there anything else we're missing here? Well, there's an S1Q3T3 pattern here, all right, and that is considered the classical sign of pulmonary embolism, and the reason further workup was pursued in this patient, okay? However, this pattern is not specific or sensitive, and subsequent imaging on this patient doing a CTA was actually unremarkable. Typically, you want to see deep S waves in lead 1, a Q wave in lead 3, and inverted T wave in lead 3 as well. So let's just take a look what this S1Q3T3 pattern is if you've not heard of it. Okay, so we can sometimes you may hear of this S1, so it's S1Q3T3. Okay, sometimes consider that classical pattern. Again, not specific or sensitive. So when we look here, you're looking at lead 1, and you want to see a deep S wave. So this is the S wave here, and this is the R wave. So these are the S waves, okay? And then when you look at lead 3, you can see these small Q waves developing, as well as in lead 3, these inverted T waves, okay? So if you look here, you can see that all, okay? That Q wave and the inverted T wave, okay? Now, again, not specific, not very sensitive, but just a pattern that you may hear oftentimes, okay? So, again, these S waves are not deep, that are causing the leftward or the rightward shift that we would see with sort of right ventricular strain pattern in a big PE. All right, so now just so you're aware, the most common ECG abnormality in the setting of pulmonary embolism is sinus tachycardia, okay? You can also see complete or incomplete right bundle branch block, which is associated with an increased mortality. You can sometimes see a right ventricular strain pattern with T-wave inversions in the right precordial leads, V1 up to V4, and sometimes in the inferior leads, 2, 3, and AVF. Now, this strain pattern is associated with high pulmonary artery pressures, and sometimes right axis shift in the ventricular axis can be seen. There may even be an extreme right axis shift between 0 and 90 degrees, so it comes over here, and we call that a pseudo-left axis. Now, dominant R wave in lead V1 may be seen and is a classical, is a manifestation of acute right ventricular dilation, and you don't really see that. You have these small R waves, okay? So nothing significant. Remember, we said our axis here was normal, so nothing that's kind of pointing to it. Now, if you had these large R waves, it would indicate a clockwise or late transition in the precordial leads, in which there's a delay shift in the R to S transition towards lead V6, with or without persistent S waves in V6. And this is sometimes referred to as the pulmonary disease pattern, again implying rotation of the heart due to right ventricular dilatation. Now, P pulmonale, a sign of right atrial enlargement, may be seen, in which there are peaked P waves in lead 2 with a height of 2.5 millimeters or greater. Atrial tachyarrhythmia, such as AFib, atrial flutter, atrial tachycardia, can also be seen, along with nonspecific ST segment and T wave changes, including ST elevation and depression, have been reported. So, just a little extra. Again, most of these things that, initially we're thinking maybe PE with this new onset shortness of breath, no pleuritic chest pain or anything to suggest it, but again, the ECG does not point to it, and that's something to know here. This S1Q3T3 pattern you may hear about is classical, but again, not sensitive or specific as we saw. Anyways, let's move on here. So how about the R wave progression in the precordial leads? Normally the R wave amplitude should progressively increase from leads V1 to V5. In this case, it does seem that we have pretty normal R wave progression. You have that R to S ratio tend to increase, right? Where the R waves, as we go across from V1 all the way up to V5 are increasing. Okay, eventually you have that. So generally a normal R wave progression in this case. Now how about the transitional zone and the precordial leads? All right, well here it appears to be between V3 and V4. The transitional zone is simply the precordial lead area where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS is isoelectric. Normally the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. And if it's after V4, we call that more of a clockwise rotation or late transition, as we mentioned, is a common thing that we see, or you may see with a big acute PE, all right, where you have that right ventricular strain. Anyways, in this case, the transition here is between V3 and V4, and we call that a normal transition, okay? And remember, transitional zone, where you're looking from it from going mostly negative. You can see it's mostly negative. You're measuring the above baseline to below baseline, and you can see again here it's almost isoelectric, but I believe it's still slightly negative. Then clearly here it's positive, so normal between V3 and V4. Okay, maybe closer to V3, but anyways, it's normal transition here. And remember, you always want to keep that R wave progression in transitional zone in the precordial leads is highly dependent on lead placement, which again is still an imperfect science. All right, so what is our final interpretation? Well, we have a regular rhythm, okay? The rate here is 117 beats per minute. That's the ventricular rate. We have sinus rhythm, a normal QRS or ventricular axis, atrial, atrioventricular, and interventricular conduction are normal. We saw a slightly prolonged QTC interval. Both R wave progression and transitional zone in the precordial leads were generally normal. Therefore, our final interpretation is sinus tachycardia, okay? A sinus rhythm with a fast rate and a prolonged QTC interval, but otherwise a normal ECG. When compared to a previous ECG, there was an increase in the ventricular rate by 43 beats per minute and a decrease in the PR interval. Previously, it was 204 milliseconds, so that first degree AV block range. And it's always important to look back and compare the most recent ECG with the previous one to make sure you're not missing any slight changes. So let's just erase this here and write our final interpretation. Okay, so again, we have a sinus rhythm that's fast, so that's sinus tachycardia. All right, we also said that we have a prolonged QTC interval and otherwise normal ECG. Okay, the S1Q3T3 pattern was not significant, so even though there was an alarm of possible PE in this patient, the ECG is still a good thing, and that pattern is not very specific or sensitive, so be cautious in using it. And then remember, when we said we compared it to a previous EKG, we saw an increase in the ventricular rate on this one by 43 beats per minute. Okay, and we also saw a decrease in the PR interval. Okay, previously it was 204 milliseconds in the first degree AV block range. Okay, now in conclusion, our 33-year-old thin male with newly diagnosed miliary TB and AIDS that developed shortness of breath has an EKG showing a sinus tachycardia and prolonged QTC interval. Unfortunately, no evidence of pulmonary embolism on imaging. Well, that's the end of this week's EKG of the Week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.